Ladies and gentlemen, thank you for joining the Interact Quality Improvement Program version 3.0 Tracking Hospitalization Rates. Your host for today, Diana Bynes, will now begin.
Thank you. Good morning and welcome to today's webinar. We are pleased that everyone was able to join us for this third Interact Quality Improvement Program version 3.0 webinar. Healthcare Quality Strategies and Healthcare Association of New Jersey are proud to support NJ Lane as part of the Advancing Excellence campaign. Today's speakers include Loretta Keys, the Director of Quality Improvement and Clinical Services at the Healthcare Association of New Jersey, Janet Noth, a Quality Improvement Specialist at HQSI, and Adrienne Mihalik, a biostatistician with the Colorado Foundation for Medical Care, where she provides technical and analytic support to the Advancing Excellence campaign. Next slide, please. Before we begin the webinar, I would like to review some housekeeping items and make a few announcements. First, I hope that you have been able to download the materials before the webinar. However, if you did not get a chance to get the materials, you may download them by going back to qualitynet.webex.com. You can follow the instructions as listed in the WebEx reminder email that was sent to all registrants. We will have a question and answer session following the presentation. We encourage you to use the chat feature to submit comments and questions during the presentation. Please be sure to submit your chat submissions to all participants. Your chat postings will be addressed and answered during the question and answer portion of the webinar. Also, your phone lines have been muted. After the presentation, the operator will open the lines to take your questions and comments. We also ask that you please respond to the evaluation questions that will be available at the end of the presentation. It helps us improve and plan for future events. Finally, this webinar will be recorded. We will make the recording available along with presentation materials on hqsi.org. Next slide, please. Today's webinar will feature an overview of the quality improvement tools of the Interact program. And if you missed the first two webinars on communication tools or on advanced care planning tools, we invite you to visit the HQSI website to view the recordings and download the materials. Next slide, please. I would now like to briefly note today's objectives. We will be discussing the ways to engage your hospitals, using quality improvement tool for review of acute care transfers, identifying strategies to teach staff, developing your root cause analysis, and receiving an overview of the Hospitalization Tracking Tool. Next slide, please. And now I would like to turn the floor over to Loretta. She will begin with how to engage your hospitals.
Good morning. As we discussed in the first two webinars, the overview of the Interact program and the end-of-life review, we have come to the time when it is appropriate to find out how we can engage our hospitals. We are no longer discussing discharge of residents. We are considering care transition. So that makes the continuum from home care to assisted living to skilled nursing care to the hospital, all members of a team that are responsible for the care transition of an elderly person safely. So in order to engage your hospital and establish a relationship with them, you have to demonstrate your value in an increasingly competitive business environment. Already, ACOs and HMOs are looking at good performers who are already measuring and tracking their data and using that data to improve their services and improve the care of the residents, making it more attractive to the hospital. Introducing better methods of communication and transition. Require clinician-to-clinician verbal handoffs, and I will be stressing this in a very short period of time. The best form of communication, safe transition, is a warm handoff nurse to nurse. Educate hospitals on your level of care qualifications using the Interact Nursing Facility Capabilities List. They have to know what you can provide and you feel confident in providing safely. So why do hospitals care about our efforts to implement Interact? First of all, they're very interested in safe handoff nurse to nurse. We want to work together with hospitals to keep residents in their home and not in the hospital. Work as a transition team, not in silos. And most importantly, hospitals are penalized for high readmission rates of certain diseases, chronic diseases. To engage and start a relationship with their hospital, with your nursing home, create a list of all the hospitals you send to or receive from. Identify the readmission champions from each hospital and try to establish as many personal relationships with staff at the hospital that you can. Make yourself a resource. Host or join a cross-setting work group or coalition. It's always a great idea to join the hospital team in discussing your successes and where either of you need to improve. State your facility's goals to reduce avoidable transfers and readmissions. Focus on prevention of acute episodes of chronic diseases by early recognition and intervention. The hospital will understand this, that you're doing what you can to intervene early on to prevent them from going back to the hospital. Actually, talk about the quality improvement projects already taking place in your facility. Tracking your data of readmissions, root cause analysis of why those omissions are happening, what you're going to do in the future to help improve that. Ask the hospital to become a partner in your quality improvement projects. Hospitals are currently working very, very hard to reduce hospital-acquired infections. If you have a good infection control program and you can share your resources and information with them, that makes you a valuable resource. We have to kind of knock down the barriers in communication with hospitals. As I said, the success of the care of the resident depends on a safe transition of care and every level of care taking responsibility for that. Partnering with facilities implementing Interact can contribute to reducing avoidable readmissions because these facilities send you a comprehensive set of transitional care information. This is what you can use in your talk with the hospitals, why you are valuable. Provide a list of your capabilities to help you decide whether or not to return the patient to the nursing facility. This is really important. It is amazing how many hospitalists and nurses in the hospital don't know what you're capable of, and that is true in any care setting. Hang your capabilities in the emergency department. Make sure they know what you're capable of. So once they evaluate the resident, they'll know what you can take care of when they send them back. Always ask for the transfer back without admission, if possible. Give it to the case managers. Give it to the hospitalist, the doctors that take care of your residents while they're in the hospital. Give it to the on-call primary care clinicians in your facility. Make sure your own doctors know what you're capable of doing before they make that decision to send the resident out to the hospital. Engage improving handoffs from hospital to nursing facility. This is very, very, very important, and the best method of communication demonstrated so far is a warm handoff nurse to nurse. Engage in advanced care planning with residents and families. This will be an important part of your success in keeping residents from going to the hospital. Consider returning the patient to the nursing facility. We discussed that just briefly, that when you send your capabilities list, make sure you think out how quickly you can get a lab turnaround, how available your mobile x-rays and EKGs. Really be preferable if you could do EKGs in your own facility. The things that are important to the hospital, ask them. Ask the hospitals, What's important to you? What do you need us to do in order to take safe care of the resident? Collaborate with other Interact facilities. Find out what they're doing, what their successes are, so you can improve. Include the Interact Quality Improvement Program as part of your strategy to reduce readmissions. This is an evidence-based program that is successful and can work to help reduce readmissions and provide safer care for the residents. Educate your staff about Interact. This is an ongoing process. It starts with the primary caregiver. If they are trained to spot signs of early status change in function or mental capacity, then you can make an early intervention that possibly can keep you from a potential hostile readmission. Develop a process to ensure the Interact forms reach staff receiving patients. That's another thing. The hospital nurse should get a warm handoff from you. So make sure you include all the information and ensure that they got the information they need. Encourage your staff to provide warm handoffs. Review readmission data and identify areas for improvement. And now Janet will speak to you about the review of the data. Good morning. Here we have the journey of the patient, and that would be represented by the white squares down the middle of the slide. You can see the Interact UI tool on either side. On the right side, you see Stop and Watch, the early warning tool, and SBAR. And on the left side is the advanced care planning tool that we've discussed in previous webinars. For today's program, I will discuss the tool for review of acute care transfers that will lead you to gaps and or education opportunities to be addressed in your facility. The quality culture needs to be prevalent throughout your facility. For staff, this means regardless of what unit they are working on, they will know the protocols and the expectations. The Interact program reinforces communication both internally as well as externally. The tools empower staff to provide the most complete report, and that standard of excellence will become the norm that your transition partners will come to expect. Your root cause analysis will fine-tune the information that will provide your quality improvement goals. First, look at your on-plan transfers closely. Do you see a pattern? Yes, we can see that Dr. Smith continues to send patients to the emergency department without interventions in our facility. Possible interventions for Dr. Smith could be review the Interact nursing capabilities list with him to reinforce the care level your staff is qualified to deliver, or review the Interact advanced care planning tool to encourage Dr. Smith to speak with patients and families sooner about comfort measures or palliative care options as the patient declines. Continue to review on-plan transfers and track progress. Perhaps you will see that Dr. Smith's patients are showing a decrease in on-plan transfers, or as you see in this graph, Dr. Smith has shown an increase in advanced care planning documentation. Now I'll turn it back to Dinah.
Thank you, Janet. Before we continue, we would like to get input from you with a polling question. The question is, what do you find is the most common cause of hospital transfers? Operator, could you please bring up our polling question? Thank you. You will have 45 seconds to respond to this question. Please select your answer. Looks like time is slowly coming to an end. As soon as we hit 45 seconds, we'll take a look at the results. If we could pull up the results, please. Are the results being displayed? We don't see them yet. Aha, there they are. Well, it looks like the delay in identifying changes in condition seems to be one of the most common causes for transfer. Now I'll be handing it back over to Janet, who's going to help you better identify those most common causes and how to respond to those. Dr. Janet.
Okay, on slide 13, let's look at the handout for the review of acute care transfers. This QI tool helps you to do a deeper dive into your on-plan transfers. Review your on-plan transfers consistently, perhaps every 2 weeks. Have appropriate staff present that can elaborate on that transfer. Let's look at section 1. This puts a quick face on your patient, who it is, what the diagnosis is, their age, and recent hospitalization. What condition puts the patient at risk for readmission? So staying on page 1 of your handout, you will see section 2A and B at the bottom. Section 2A is, when was the change noted? Now, the completed stop and watch tool might have started this conversation. Section 2B, describe the changes that precipitated the transfer. Now you should be on page 2 of your handout at the top of the page. And look at C. Under C, check all that apply and use as much detail as you can. There should probably be check marks in each column. And then look again at C and circle the main clinical factor and the main contributing factor. So this will grab your attention for your overview, but it will also allow you to visualize the detail. Now, the main clinical reason may be shortness of breath, but the contributing factor was that the person had no advanced care planning documented. Now, on slide 15, you see section 3, but you will stay on page 2 of your handout. Section 3A, describe the steps you took to manage this change in condition. What evaluation was done, and how was the change in condition managed? In section 3B, list the tools. For example, if SBAR was part of the protocol for on-plan transfer and that box is not checked, you know you need to address this with the clinician responsible for the transfer. What evaluations took place? What tests were ordered? And the intervention. So now please go to page 3 of your handout, and under 3C, comment on advanced directive. Was there one, or was there a palliative care or hospice consult order? Now in section 4, which we're on slide 16, section 4A, they want to know the date, what day of the week, what time. You can narrow it down to the shift. Section 4B addresses the clinician. Was it the primary or was it a covering physician? And how familiar was this physician with the patient? Part C looks for outcome. Was it the emergency department only? Was it observation? Or was that patient admitted? And if you can find the hospital diagnosis, you would list it here. And then they also ask if the patient did expire when they were transferred. On slide 17, we see section 5, and this is the tool, part of the tool that will bring you to your opportunity. In part A, do you think this transfer could have been avoided? Check all that apply. Could the problem have been detected earlier? Could there have been better communication? Were resources available to manage the patient safely? What resources would have been utilized if they were available? An on-site physician, an APN, pharmacy? Could you have advanced care planning discussions earlier? And in part B, do you think you could have transferred this patient sooner? In part C, they want your team to identify opportunities for improvement. And then, of course, you would sign and date the review of this transfer. And on slide 18, we again see the Interactive Quality Improvement Program. We just covered the use of the tool for review of on-plan transfers, important to remember to close the loop and to use that information to improve processes and improve and educate your staff. Interact can help you achieve the results you desire to improve patient care. Know your data, focus your efforts, and keep your staff in the loop. And here on the slide, you'll see the Interact website. Dinah will bring us to the next polling slide.
Thank you. And now the question is going to be slightly different. The question is, what do you find is the most common cause of avoidable hospital transfers that you can act on? Operator, could you please open up the second polling question? Thank you. Again, you will have 45 seconds to select which avoidable hospital transfers you can act on. And as time is ticking down, we'll soon be seeing the results. Operator, if you could bring up the results, we can take a look at those. Very exciting waiting for the results. I'm sure it'll be up in a moment. There they are. And it looks like it's about a tie between the delay in identifying change in condition or incomplete evaluation before calling physician. So as we now move on to the second portion, it will be covered by Adrienne Mihalik. Let's pass the ball over to Adrienne. Bear with us for just a moment. Adrienne, do you have the ball?
Yes, I do. Thank you so much.
Absolutely.
Okay. Well, thank you all for joining us. I'm really happy to be working with you all today, and this is just a terrifically exciting introduction. It's very rich the way all of the bits and pieces are being tied together. So I wish you all well as you dig into your projects. Today, in this portion of the presentation, we're going to be doing an overview of the Advancing Excellence Safely Reduced Hospitalization Tracking Tool. We're going to be looking at the capabilities of the tool, the features, the functionality, and the kinds of information that the tool can provide, and an introduction to how that information can be used. And again, this is an overview. There's a lot that can be done with the tool, and in some ways it can be a little overwhelming. So what we're going to do is, following this, starting tomorrow, we have a series of 3 practicums on actually using the tool, where we'll be getting into the mechanics of the tool, and we'll step into it gradually over a period of several weeks. And I'll be talking about that a little bit more later in the presentation. If you haven't received an announcement about this series already, look for an email following this webinar. I'm going to talk for a moment about the Advancing Excellence campaign because you're going to get the most from using your tracking tool if you register for the campaign for a specific reason. Okay? The Advancing Excellence campaign is a national campaign that's partnered with a number of major initiatives, including QAPI, QAPI, the National Nursing Home Quality Care Collaborative, CMS's new partnership to improve dementia care, Interact, the CDC's initiative on reducing C-difficile, and so on. Participation in the campaign is voluntary. In some states, it's actually become part of the pay-for-performance plan. Registration is free and allows you to participate fully in the campaign. And so this is the important part. A hallmark of the campaign is that we provide tools for data collection. We actually provide entire turnkey packages for the Quality Improvement Project linking you to resources for all parts, all steps in a quality improvement project, but including these data collection tools that can be used to support your quality improvement project. So tools that inform your quality improvement project makes a happy copy, and if you submit your data monthly to the Advancing Excellence website, you get a couple of really important things. You get access to real-time trend graphs of your progress. You'll get comparative data within the state and the country. And it keeps your participation status active. And this is just an extra bonus. We have a beautiful digital map that we're going to be rolling out shortly. And any visitors to the site will be able to quickly locate your home, and active participants will have, whatever the good color is, green, and clicking on that will bring up a little calling card with contact information that you've customized, including your website if you'd like. But in terms of the quality improvement, the reason for the active participation is that you get access to those trend graphs and the comparative data. And I think that's well worth it's an extra 5 to 10 minutes a month to actually submit your data on the website. So I'm going to encourage you now to do that. And I'm going to give you information on registering. The website's down here at the bottom of your screen, www.nhqualitycampaign.org. We have links to the help desk. If you need help getting started, there's a button to register. It's quick and easy. When you register, you'll need to select goals. There are 9 goals, the ones that you see here, and we have entire packages, again, to support quality improvement projects in each of these areas. When you register, you'll need to choose one of the organizational goals, and those are in red, so you'll probably be choosing hospitalization, and one of the clinical goals, those are in blue. The organizational goals we consider your foundation. Hospitalization is an organizational goal in our view because working on this strengthens infrastructure, communication, and processes in such a way that you're going to expect a widespread improvement in quality beyond just reducing the transfer rates. To complete the registration for the campaign, again, you choose one organizational goal and one clinical goal. But for the first year, you only need to submit data on your organizational goal. So you dig in with hospitalizations, get that quality improvement project well established. You're submitting data on that every month. And then when you're ready, start digging into your clinical goal. Now, there's no restriction on that. That's just that's the basic requirement. If you want to choose 5 goals, and people do, you may choose as many goals as you'd like, and you may begin submitting data on them as soon as you'd like to do that. Now today, of course, we're focusing on the hospitalizations goal. Here's the flow chart that we were looking at earlier. And down the middle, we see sort of events in the life of the nursing home. So a new resident is admitted or a resident is reassessed. There's a change in the resident status. And clinicians are brought in, there's an evaluation, transferring clinicians are notified, and maybe a care transfer occurs, and then down at the bottom, the quality improvement and so on. So along the sides in these blue boxes are actually not even all of the Interact tools. So Interact is a complete program that you wrap around this process. It is a way of doing the work, a pervasive way of doing the work, and it also includes this wonderful package of actual tools. And again, there are more tools than what you see on this particular one. For example, the nursing home capabilities checklist, which is so important, actually is not on this particular slide. Now, in the way I organize these, I'm looking for there we go. The tools that are in the blue box, these are ones that we use in our home, potentially on a daily basis, but we're using them within the home as an event is occurring or during our what I'm going to call the daily process. So implementing the advanced care planning tools, using a MedRec worksheet. These things happen early and often. Change in conditional file cards. At the time when a transfer is actually occurring, the tools that are in the green boxes come to play. And today we're focusing on the tool used to monitor and drive your quality improvement project. The quality improvement tools live here in this red box. We just heard the introduction of the quality improvement review tool, and this is a really important, it's the best way to get the most out of your hospitalization rate tracking tool, which is what I'm going to be talking about now. Okay. And we focus on the tracking tool for two reasons. And one is that quality improvement is a science. And monitoring your processes and outcomes is the key to a data-driven quality improvement project. That's what QAPI is looking for, quality is looking for. So it would be one thing to bring in the care paths and the S-bar and the strap and watch, and you're using those. And those are all wonderful things to use. But we know, let me just use the example of I'm going to do my weight loss plan. And I'm trying to improve my diet, I'm trying to incorporate more exercise. If I'm not logging that, I have a sense of where I'm going or of where I want to be. But I'm sure that we've all had situations where we thought we were doing a little bit better than we were, or in certain situations we're doing fantastic. We know that in other situations things slip, but we're not aware of how often those other situations are arising. So using data to drive the quality improvement project, it makes for a more informed quality improvement project, and it kind of keeps us on target. So the second reason that we like to talk about the quality, about the tracking tools, is that the advancing excellence tools aren't just about record and report. We're not talking about another data entry task that you enter the data and you send it off and we're not looking at it. It's more than that. Not only do we look at it, but the way these data collection tools work, they relate to all stages of the quality improvement project. So this slide shows the circle diagram here. This is the advancing excellence version of a quality improvement project. So you can even think of it as an elaborate PDSA, plan, do, steady, act type of cycle, where you identify the baseline and set the target, examine your processes, that's the, and creating improvement as you're acting. Leadership and stakeholders, these are fact sheets we have, but in terms of the process, I've circled this as the creating improvement and involving stakeholders. This is an important way to drive quality as well. And of course, monitoring the progress. And then this loops around and we do next a series of this cycle. We'll see versions of this image on the coming slides, reminding us what part of the QI cycle we're talking about. And when we think of QAPI in this session, we're going to focus on this distinction. Quality assurance is associated with a reaction to a single episode or event. It's basically trying to figure out what caused an event. Event-level root cause analysis is a common tool for QA. The Interact QI review tool that we just looked at, that handout, is an outstanding template to guide an RCA around a specific transfer. Performance improvement asks us to look for patterns and identify opportunities at the process level that we can leverage to make a system-level change. That requires summarized data, and it requires continuous monitoring to ensure that changes made a sustainable improvement. So information from your individual quality improvement review tools can be entered into the tracking tool, which is an Excel workbook, to get this kind of aggregate data. So you do both. The individual level is your QI review tool, and forget this, this part at the bottom as sort of a relic, but you know what we're talking about, right? That sometimes you have an adverse event, and the root cause analysis is sort of finding out what went wrong. Well, QA doesn't have to be like that. It's very, very useful to do something like the QI review tool and look at each individual transfer to determine what happened, but then we want to look for patterns to decide where is the best way, the best place to focus our first next step to rework a process, a communication procedure, to affect not just one case, but many cases. And that's why we want to look at aggregate data. The Advancing Excellence Tracking Tools for all of our goals let you see individual data as well as summary information. They include both process and outcome measures, and they offer options to start small with your data entry using just a few required fields. And that's an important thing because this can look a little bit overwhelming. We have ways to step in and take small and manageable bites. The tracking tool is an Excel workbook that you download from the Advancing Excellence website. And again, today we're not going to look at the mechanics of the tool in much detail. We have illustrated instructions on the website. And again, we're kicking off a series of practicums beginning tomorrow to get into the mechanics of using the tool and actually entering the data step by step. When you go to the Advancing Excellence website and download the tool, it gets a little bit confusing because I talk about entering data on the website. I'll show you what part gets entered on the website. The Excel workbook, and you actually click on the link, not on this icon that you're going to see on the website. This is a screenshot from the website. You'll click on the actual title of the tool, click on this, and it will download or open the tool. And your first step is to save that to your computer. It doesn't live on the Advancing Excellence website. You're going to be putting individual resident information into it. It will contain their personal identifying information and health information, so you'll protect that the same way you do with your other records. Now, again, what we are going to focus on is the kind of information that you'll be able to get from the tool and how to use it to inform your quality improvement project. And I'll be talking specifically about the hospitalization tool because hopefully you will be also registering for the campaign so you can access those other features. Know that the general idea, the kinds of things that you see from this tool, are available in most of the other tools as well. And so specifically also, a take-home point about this tool and all of the others, and any work that you do with data, is that while you track the data to inform your quality improvement project. So it's meant to be formative. It's not just something that you look at the end of the day to see how you did, but use it along the way to make sure that you're staying on track, to see where your opportunities are, and when you make a change, if it's having the effect that you intended. Okay, so I mentioned that there's a way to start using the data with a small, manageable amount of data entry. There's a lot, just as with all the Interact tools, there's a lot of process to get established. For example, when you use a care path, which one are you going to start with? Where are you going to put it? Who's going to get trained on it? And then how do you spread that information? And so likewise with data entry, there's a lot of process to get established and work out. So you're going to see a lot of data entry options when we look at the tool, and that can be overwhelming. So here's the starter set. And I really recommend that you start with just these required fields for maybe the first month or the first few weeks. So the first thing is, for all residents that were recently discharged from the hospital, and by this we mean, if you have residents that are discharged from the hospital directly to you, you'll enter these three pieces of information: their name, the date they were discharged, and when you admitted them, are they on Part A or other, status on admission. If they were discharged from the hospital but went home first, to an assisted living, to another nursing home, whatever, but then still within 30 days from the date of discharge from the hospital, you'll also record just these three pieces of information. So not for all of your admissions, only for those that had a discharge within 30 days of the date you admit them. Then, whenever you transfer a resident to the hospital, 4 pieces of information: name, whether they were post-acute type or long-term care. When we say post-acute type, because this can be really post-acute, or it can be maybe they were admitted on managed care, but it's from management of a complex medical condition or rehab, something like that, that you would consider them post-acute type care. The date they were transferred to the hospital, and this is the only tricky one. the outcome of transfer, and this may be the first opportunity to work at establishing those better communications with the hospital. What happened to that resident when they were transferred? Was it ED only? Were they admitted? They stayed overnight? Was the observation stay only? We need to know this information. It's very important. And then finally, at the end of the month, enter your average daily census, or it could be a mid-month census by purpose of stay. So that's a total of 7 plus 1 items, but it's not for every record. 3 for admissions from with a hospital discharge, 4 when you transfer a resident, and then the summary information. Many homes are finding that it works well to use a daily report that either already exists or maybe there's a field that needs to be added to it. Maybe you can have somebody at the front desk enter this information. However, you don't want it to stay in your administrative office or at the front desk. By just entering this information, here's what you get. Here's what the fields look like. This is the data entry, and let's just talk about how this works, first of all. As we admit residents, again, we record only those that come directly from the hospital or that had been discharged from the hospital within 30 days. And just the 3 fields, so resident name, and we asterisk them so you can see which ones are required. Resident name, hospital discharge date, and your status on admission to nursing home. So just those 3 are required. It all works via drop-down list. Earlier you will have created a list of residents. The only field that you type in is the dates. And this one here, you can also see how that drop-down list is activated. And there's a little window, a little message that pops up clarifying for you if you're not sure what's post-acute and what's long-term in this case. When those get in the way, you can just grab them with a right click of your mouse and pull them to somewhere where they won't be in the way. That's the data entry. Well, what to get out of it? Immediately what you're going to get is this. These yellow highlighted names of people who are still within 30 days of the date they were discharged from hospital. So at the top of the sheet, today's date, this is read automatically from your computer. So you'll check that and make sure that's correct. If it's not, you're going to talk to an IT person about that. But this will show you today's date. And if the date the resident was discharged from the hospital is within 30 days of today's date, we highlighted yellow. Well, this immediately creates for you a list of people who are technically at risk, just by definition at risk of becoming 30-day readmission, because if they are transferred back to the hospital and admitted within 30 days of this date, of the date they were discharged from the hospital, they are called a 30-day readmission. So have whoever's entering the data print this out, pass it to the clinical staff. This is a priority list for what some are calling your daily hospital walking rounds. It's the first opportunity to intervene. Another thing I want to show you on this sheet, you'll see hyperlinks above some of the columns. Provide these hyperlinks. Sometimes it's providing more information on what should you enter here. In this case, it's how to de-identify. These codes are provided so you can de-identify your work if you need to. Down the line, there are some, for example, one is asking about a structured transfer tool. If you want to know what is a structured transfer tool, I want to get started with that. Click on the link and it will take you to information and resources. So kind of context-relevant information just handy there for you. So that is what we call the Admitted with Recent Discharge tab. Down here at the bottom of this is a screenshot of the Excel workbook, so you can see all these tabs. We're just doing an overview. So we've looked at the Admitted with Recent Discharge tab. The other data entry sheet is the transfer log, and we're going to go there next. There's the transfer log. It works the same way. You only enter unplanned transfers to the hospital. The 4 required fields have a red asterisk, so the name, purpose of nursing home stay, date of transfer to the hospital, and if we were to scroll over a little further, and I may have another slide on this, but you would see the outcome of transfer. The other fields are optional. Only the dates are typed in and everything else is entered with a drop-down list. Transfers identified as 30-day readmissions are highlighted red. So again, you're already getting this just from these few required fields. You'll get to see which transfers ended up being 30-day readmissions. So this individual record view can act as a cover page for root cause analysis, and it may also be useful for detecting patterns. And again, as you begin looking at your processes and enter some of the optional data, you may want additional information on resources, and the links at the top of the columns will take you to those. And you'll see those when you open the actual workbook. They're over to the right side of the screen where you get into some of the fields that have those hyperlinks on them. I had mentioned using this as a cover page, and on the admitted with recent discharge, I had mentioned printing that page and passing it to the clinical staff so they can do daily hospital walking arounds and just ramp up the communication and follow-up among those residents. The pages do not print easily as a whole, so you'll want to customize that a little bit and just print the parts that you need, perhaps just a list of residents. Now, the other thing we get from the required fields, and the reason that they're called required, is that those are the fields that we need to calculate the outcomes. This is a screenshot of a monthly outcome page. This is February 2013. There's a page like this, and it's just this part here. I've added some text in on the side. It's this page here. And you have one for every month in the calendar year. And it provides outcomes, 4 different outcomes: your 30-day readmission rate, hospital admission rate, rate of transfers to ED only, and rate of transfers resulting in observation stay. And then these are broken down by post-acute care and long-term care. And then you get it for your house overall. These are the numbers that get entered to the website. It's only this. And so the instructions here at the top of the page tell you to wait until a particular day, and that's the day when the data are done. You have to wait 30 days after the last day of the month for those 30-day readmission rates to be final, to be mature. Then print this tab, and this one does print out well. You're going to get that on one page, and I recommend doing that. It just makes data entry much easier. Click on this hyperlink right here. It takes you to the login page of the website. You log in with your username and password, and go to click a button that says that you want to submit data, and you're just going to type in these numbers. So it's very fast. You click submit, and at that point, we're rolling out the graphic displays very soon now for the hospitalization and other goals. So you'll be able to see trends of your data and access comparative data as those become available as well. Now, I mentioned that the tool tracks processes and patterns as well, and to do that, you use optional fields, and these are the optional fields. You may pick and choose among them according to what's meaningful to you, and you may start with some and then build up over time. When I mentioned the series of 3 practicum we're going to do, for that first series, we're just going to get started using those required fields, the 3 for the admitted, the 4 for those that we're transferring, and our denominator, that census number, for the first session. The second one, we'll do this. For every transfer during the month, we'll use the Interact QI tool that was presented earlier in this webinar. When you've done that, there's a field to enter yes or no. It's a little drop down. Yes or no. With a root cause analysis of the transfer complete. Every time you've used the QI review tool for the transfer, you'll select yes. We also saw circling the primary clinical reason for transfer and the primary contributing reason for transfer. You can select from a drop-down list your primary clinical and your primary contributing. We'll just be adding these 3 extra fields of data entry for our second session. And when we do that, here's what we get. first of all, we can use the tracking tool to track the implementation of the QI review tool. So you can see that there are a number of different processes that I can track. In this case, I'm just looking at the percent of all transfers for which a root cause analysis was complete. So, for example, the state of Alabama, all their homes have decided to use the Interact QI review tool for 100% of their transfers. And of course, that's not perfect out the gate, so they will be checking yes, that they did a root cause analysis for each of their transfers as they do them, and they'll be able to see their progress over time as they work on implementing that change in their processes as they approach 100%. And of course, you can do this with some of the others. If you use the transfer tool, advanced care plan, documented in the past quarter, or reviewed at the time of transfer. So you have these other options as well. This is the way we're going to get started in the practicum. And the reason that we're starting there is the other pieces of information you get. For primary clinical reason for transfer, when you enter this, you'll get a bar chart that will provide you with some feedback. Now, I thought it was wonderful that we had a lot of non-response to the question. What are my main reasons for transfer, and what are the main reasons that I can affect for the transfer? Sometimes we don't know, or we think we know, but unless we're collecting data, we don't really know. This is one of the pieces of information we can use to try to prioritize where we're going to start, or get more of a look at what's going on in our home. This is completely fabricated data. You may just have a few of these, or you may have many. You may not have such a distinct pattern, but it will still be some information to guide your thinking and questioning about what's happening and where your opportunities lie. So one of our quality improvement tips is to start small and prioritize. So we might use information like this to select one or two care paths to implement. There are a lot of care paths, and implementing them all of them all at once might just lead to confusion. It might make more sense to just choose one or two and get started with those, figure out how they work, who needs to be trained, how that needs to happen. Once everybody's comfortable with those, then adding in the rest of them will be more straightforward. And depending on what you see here, you might even branch out and choose a clinical goal. So, for example, if you saw something like this where you've got a lot of transfers resulting from altered mental status, for example, you might choose to pick up the Advancing Excellence antipsychotic med tool, tracking the use of antipsychotic medications, or perhaps the Managing Infections tool, if you're seeing UTI or a lot of GI type. So there are toolkits. Just reminding us that this is actionable data. It's nice to know why are we transferring residents, but if our goal is to ensure not that we're not transferring residents to the hospital, but that every transfer that does occur is appropriate and timely. And those that didn't occur were appropriate to not transfer. We want this information to be actionable. So these are just some tooltips where our next steps might be given information that we see in this chart. So again, primary contributing reasons for transfer, and this is one of my very favorites. So note, again, I've got our quality improvement process circle up at the top. We call that our circle of success, and we're examining processes step in a circle. And this is the study step if you're thinking in terms of PDSA, Plan, Do, Study, Act approach. So this graph lets us look for patterns and contributing causes. We're looking for opportunities to rework a process at the system level to bring about sustainable, widespread change. I can use this information, I can use my data along with my expert knowledge of my organization, our culture, our processes. On the Advancing Excellence website, we have probing questions. And these are, if you think of process-level root cause analysis, they're questions to guide that. So get together with the team, pull those down, this tab, everybody's knowledge of what's going on the floor, and use those as a package to look for the opportunities. I might decide, given it's stated, that a good place to start would be with ramping up work with advanced care planning. There, advanced care plan not in place. Maybe with some consumer education, maybe using Advancing Excellence fact sheets for families and residents on the good reasons not to prefer a transfer, and information on details of care that can be provided in-house. So we've talked earlier about the nursing home capabilities checklist that Interact developed. Well, Interact was part of the team that developed the Advancing Excellence Tracking Tool we're looking at right now. And the work group developing this tool liked that capabilities checklist so much, they thought that maybe it would be useful for families also to have a version of that tool, something that was family-friendly, a little less technical, that they could use to understand what could safely and competently happen in home to support a more educated exchange of and a more informed exchange of information between families, residents, and the home. So that's also available on the website. Now, I could also decide, over here we have NP-NPPA decision, and there's also here practitioner unable to provide face-to-face. So looking at those combined, I might think that strengthening our partnerships with providers ordering transfers and helping our hospitals understand what our capabilities are might be another good place to go. So I might be using the Interact SFAR or the Structured Communication Tool, the Nursing Home Capabilities Checklist. So in any event, the information is actionable. We use it to select an area to get started with some of the other Interact tools and Advancing Excellence resources. So now in the third cycle, I'm coming back to my optional fields with that information in hand, what my primary clinical reasons and primary contributing reasons are, having looked through those probing questions on the website, met with the team to bring all of our experience and knowledge of the culture and so forth to play. And in my example, as a result of exploring my patterns and processes, I decided that for my third round, I'm going to work with the Documenting Advanced Care Plan. And this would be my ACT step in a PDSA cycle. So I go out to the Interact and the AE websites and access the materials to support doing really great advanced care planning and start getting those ACTs in place, up to date, and most importantly, integrating the step of reviewing the advanced care plan every time a hospital transfer is contemplated before it is already in progress. Then, as a way to monitor this, I can record whether the advanced care plan discussion was current, that's my blue line, and if the advanced care plan was reviewed at the time of transfer for each transfer that occurs. So again, I'm monitoring my process. I'm using the tool to monitor the implementation of my quality improvement project. So I've got my process piece popped out here on my circle of success, and also my monitoring, my outcomes. This is a kind of outcome. It's often useful to use process measures as the outcome in your quality improvement project, especially during the early stages. Hospitalization rates, especially if you have just a few readmissions each month, can be volatile, or a few transfers each month. They can be really volatile. And it's also a very complex process with many contributing factors. So it may take some time before you see a consistent reduction in transfers. So back to our weight loss program, I may have to adjust the amount of food I'm eating overall, and then I may want to be more specific about sugars, fats, carbohydrates, something like that. I may start with one exercise program, but it's not quite what I need. I need to to do something more cardio. You get the picture. We work these processes, and it's not that any one of those changes, if I don't see an effect immediately, didn't improve my health. It's that I need to accumulate a number of changes and continue tweaking the process until I start seeing an effect on the outcome. They're all contributing, but I need to accumulate them. So we're waiting to see that the change in our distant goal, having these more proximate targets that we can look at can be really motivating and help us ensure that we're on track. So again, while it may take some time before you can see a consistent reduction in transfers, looking at process measures help you see how well you're implementing the improvements in your processes along the way. And each of these, just as the different changes in our diet and exercise regime were helping our health, or improving our health, even if we didn't see the actual weight loss that we're looking for, these will help. These will result in an improvement of quality of care and quality of care for your residents, and help ensure that each transfer or non-transfer is appropriate. There are other optional fields I wanted to note that are handy for identifying patterns that help prioritize. So remember to start small and start smart. So here I'm highlighting, for example, hospital. You can include the hospital from which your resident was discharged, and the clinician, for those who are transferred to the hospital, the clinician who ordered the transfer. And when you, among others, but for example, the tool is automatically going to display for you the 5 hospitals from whom you are most frequently admitting residents, and 5 clinicians who are most frequently ordering transfers. So knowing these patterns, and you also get graphs, the time of day, the day of week, things like that. Knowing these patterns, again, may lead to opportunities to leverage communication. So this is meant to be actionable. If I want to begin using a transfer form with my hospitals, I'm going to pop back to that one. I might start by partnering with, in this case, it's Rose, to decide exactly what to include and to establish all the communication channels and so forth, so they know how to use that information on the receiving end. Once I have that in place, I can branch out to my other hospitals. So just where am I going to get the most bang for my buck when I kick that part off? And likewise, when I begin using the S-bar, and this is just an example of how this information might be used. I might start, in this case, with unfortunately named Dr. Jekyll. Data is a terrific way to engage partners in the quality improvement project. The graphs I've been showing you, let's see, so here now I've got leadership and stakeholders selected and creating improvement. All the graphs I've been showing you, they're actually, I pulled them directly out of a copy of the tool, and you'll be able to do that also. They're all selectable within workbooks, so you can print them, you can paste them into your PowerPoint presentation, a Word document, print them off and share them with your teams and your leadership. And hospitals are such critical partners in the care transitions that we offer some special features to support this partnership. And this feature was actually recommended that the state of Arizona was using this tool in a pilot test, and they recommended that we include a way to customize some data displays for hospitals. So what you're seeing here, on the left-hand side of the pane, I have a little drop-down list that will have been made previously, just by entering the names of the hospitals from which you receive residents. And if I click this arrow, it would pull down a list of those names. I can choose the hospital of interest, so in this case I've chosen Inverness, and it displays the 30-day readmission rates for Inverness. And the green line is the residents that we admitted from Inverness on Part A, The purple is the not part A, and the blue in the middle is the combined, and there's a table of numbers below. The screen we're seeing now are item summary tables, and we've been looking at the individual item summary tables just screen by screen. It's on a sheet like this where we see those 5 hospitals from which we're most admitting residents and the 5 clinicians that are most frequently transferring residents. We also get a graph like that for day of week, time of day, transfers by outcome, and then of course we also looked at the primary clinical and primary contributing reasons of transfer. This set of those bar charts can be produced for a specific hospital. This is wonderful when in your collaboratives within your community you are working together in partnership to reduce those 30-day readmissions for which you'll be jointly accountable. Great information to share and establish that relationship and information to drive the project. So then back to basics. This is a screenshot of those 4 outcomes that are calculated for you. We looked at that earlier. So as you're working the quality improvement project and with all that process and pattern level information, you'll be keeping an eye on the outcomes. So again, each month, this is like stepping on the scale. On the date that's indicated for you on the sheet, on or after that, you can print out this page, click this link, sign in with your password, click Submit Data, and you'll type in the numbers that you see here on the screen. That's the only information that you send out. It is all confidential. No individual nursing home information is shared with anyone. You're the only one who gets to see your individual results. But you will be able to see your individual results compared to an aggregate within your state and within the country as data submissions permit. Obviously, we don't share that data if they're not enough to ensure confidentiality anonymity. And this is what the data entry looks like. If I click on that link and say that I want to submit data, I will select the month, I'll select the year, and these are the fields that I'm going to type in. At the bottom, I click Submit, and my data is submitted. It's really just that easy. You'll see the trend graphs, the comparative data, and remember, it maintains your status as an active participant. You'll be displayed as such and be able to provide customized contact information for your home. Thank you so much for hanging with us for this. Remember that we do have a series of free practicum coming up. You'll be getting an email following this webinar with details on that. This is my contact information, and I believe you have access to these slides, so you'll have that also. You're welcome to jot that down. This is my my work email. The help desk at the NH Quality Campaign is the Advancing Excellence help desk. If you're writing in with a technical question about the tool or about working your quality improvement project, if it's most of the tools, I'll probably be working with you on that, and you're also welcome to just give me a call if that suits you better. Thank you so much. And I think it's time to queue us up for questions and comments and any discussion you'd like to have.
Absolutely. Thank you very much, Adrian. If you could pass the ball back to us, that would be wonderful. And as Adrian was noting, we will be opening up for questions and answers at this point. If I could ask the operator to please open up the lines and instruct participants how they can get into the queue, that would be wonderful.
Ladies and gentlemen, if you have any questions, please press the number 1 key on your phone. Again, ladies and gentlemen, if you would like to ask a question, please press the number 1 key.
Thank you. And while we wait for questions to come into the queue, we do have some chat box submissions. The first one was from Sandra Siciliano. Her question is, can these tools be used with home health?
Yes, ma'am. So in terms of the data collection tool, the data collection tool may be used with home health. We're very interested, and I believe there are a few home health agencies that are piloting the tool, and I'm looking forward to feedback on any changes in fields or language that need to occur. I think most of it is the sort of thing that if you know what we're looking for, you can do the translation, but we'd be interested in modifying the tool as well. So if you would like to pick up the tool and begin using the tracking tool in home health and let us know if there are specific changes, modifications, additions that you need, we would love to have that. The Interact program overall is recapitulating all of its tools for home health as well. But I do know that a number of home health agencies have gone ahead and picked up the tools, and they're just using them as is as well. So I don't know if you all in New Jersey have some additional information you'd like to weigh in on that.
That's a wonderful opportunity, but yeah, I mean, if we can have folks reach out to you and things like that as they use it, that's great. Do we have any questions on the phone line?
Yes, we have one question from Natalie Torres with Sutter Crest Village. Natalie, please go ahead.
Okay, my question was, when she was reviewing a slide in the primary contributing reason for transfers, I was wondering if you can actually customize those diagnoses. I know that there's an other tab, but if it's missing a diagnosis, can I input a diagnosis?
Unfortunately not. On your QI review form, which is currently pencil and paper, and they're going to have an electronic version of that soon, but for this particular, what we're setting up right now is using the pencil and paper with the Advancing Excellence version of the tool. You can check all that apply, you can write in if you want to, whatever you want to do there. When we put it in Excel, we're not able to customize that at this point. However, the list of primary clinical reasons is the Excel list. I worked with Dr. Alsander on that list that we put in there. And the way and we've actually added one more. I think that cerebrovascular events hadn't existed. We wanted to put that in there. But that particular list was designed to interweave with the changing condition file cards and the care pads, and it's meant to represent their thinking about the changes that you're most likely to, I'm trying to get my syntax right for this, the ones that are most likely to be avoidable. So they were strategically chosen for that. So it's not actually meant to be a comprehensive list of everything that could have occurred. What we want to be able to do is collect with a finite list the ones that are going to be your best targets. Does that kind of make sense?
It does. Thank you so much.
Thank you. We would like to move on to a chat question now, probably for Adrian. This is a question: does the Interact Tracking Tool provide all the information that needs to be uploaded and submitted each month?
I would like to clarify with the asker of the question if they are making a distinction between the Interact Tracking Tool and the Advancing Excellence version. Is that what the question is? If they wanted to use the Interact version of the Tracking Tool versus the Advancing Excellence, can they use the Interact version to participate in Advancing Excellence? And I'm going to go ahead and answer that. I know it's going to be confusing to most of the audience. The answer is yes. You can. They are, I actually developed both of them. I mean, I did the work to build both of them. And they're identical. Their substructure is identical. And the calculations are identical, and yes, you may use that to participate. Dr. Alsander needed that version for some study participants in the way he had written the grant. That particular version includes a limited number of fields. There are, if you compare them, all those process level measures, the advanced care plan and SBAR and root cause analysis and so forth. Those are not available on the Interact version of the tool. And you'll see links out to the Advancing Excellence version of the tool on his website. If he worked with us on this is his design as well. So you can use either one if you have cultural reasons or if you're one of his study participants and need to be using that Interact tool, but it's just a kind of a more delimited version of the A version was developed first and has a fuller set of fields, and the Interact version is pared down. What we literally did was to cut out some of the fields.
Wonderful. If I can ask Selena to maybe chat back if that answered her question. In the meanwhile, if I could ask if there are any other questions in the phone line.
There are no questions in queue.
Okay, then we'll move on to the next chat question. This is from Joseph Sufio. Sorry if I misspelled that. The question is, we are using Interact Excel forms now. Should we switch to Advancing Excellence?
That is entirely your choice. I just went through the description of what is the same and what's different. You're welcome to call me or write me to discuss. If you would like to move your data, if you want to have those process fields in there in that same tool, and I love having the process and the outcome together, both philosophically, because the process is related to the outcome. So I don't want to do that separately. That's my philosophy. But also practically, so that you don't have to maintain multiple tools. You've got it all there. And at a high level, it's a usable amount of information, not too much detail. I like that. If you'd like to move data, that's a pretty simple thing to do. I can help you with it. I also have a WebEx up on the Advancing Excellence website about moving data, and you're going to just go, you're going to select just certain columns and move them in chunks because you're going to, in some cases, I think you skip over the fields that don't exist in the version that you're using, but it's a pretty straightforward process, and there is a WebEx up just on the mechanics of how you move the data. And it doesn't take too long, so it's not a huge thing if you would like to do that. And I don't know, New Jersey, if you have a particular recommendation for how, what you're going to recommend for your homes to do.
Excellent. I think at this point, let's see if we have another question in the phone line.
There are no questions in queue.
Okay, then we'll pop right back to the chat box. This question is from Margaret O'Brien. Overall, what are the biggest pitfalls for an all-paper environment to engage these tools? No EMRs, OEs, or clinical documentation electronically. Are other participants in an all-paper environment?
Did you want me to take a go at that, or are there other participants that want to chime in?
Loretta, this is Loretta, and from what I know, there are still, in New Jersey, some all-paper environments, but everyone is being encouraged to move toward electronic records, as far as health records, medical records, and MARS. So I think that's not going to be, the paper environment will not be here for a long period of time.
Mm-hmm. I would agree with that, and I think that you're going to love getting some of your information automated to any extent and collecting it. It's just a different view of what's going on. I will say that for using the Excel tool itself, it's just a matter of learning to use the tool, and we've got a couple of supports for you. One is that there are illustrated instructions up on the website, and I'm sorry I should have mentioned this earlier, where you download the tool, and we have a handout that we can also send out. Actually, I'll send that to you to go with the webinar announcement for the series that's coming up. On the page that has the tool itself, there are illustrated instructions. They're illustrated with screenshots of the tool and captions. So it looks long, but it's actually pictures with just little captions about what to do where. So that's one hurdle, is just getting used to using Excel, and that's a hurdle for all of us, believe me. You have live help desk support all the time, and this is not over, you can email me, but we can also talk over the phone. I do this every day for several hours. And again, biggest pitfalls, I'm just looking at the question, biggest pitfalls for an all-paper environment. And, a lot of this is really, you're going to have probably your business office is calculating your average daily census. If not, you can do a mid-month count, and we can talk about how you do that. And again, the QI review tool is pencil and paper. So this is a nice bridge from doing pencil and paper and a team meeting and getting that completed, and then taking that to a workstation and entering a few pieces of data. So, see how it goes and let us know, because I think that's of interest to all of us. Everybody's in that transition. So, and I'm going to go ahead and answer. I can see the next chat question about can we use the tool even without signing up for the program. You may use the tool. It's all free and publicly available. CMS is paying for this for you, and you may do that. What you're not going to get is that trend of your progress over time in the data displays that come from submitting the data to the website. And it's just, it's 10 minutes a month at the most, and access to that comparative information. And they're actually I guess that was the same person, same question twice. No, you don't have to sign up in order to use the tool. You go to the website, and we'll send out a handout that shows you how to get to the website. It includes information about how to register as well. And I do hope that people will do that. But if you don't, it's also going to show you how to get directly to the page to just download the tool and access all of the other resources we have as well. They are all free and available to you.
Wonderful. I'd like to ask if there are any questions in the phone queue at this point.
There are no questions in queue.
Okay. In the meanwhile, if any other questions come into the chat, I can just quickly address that the practicums that Adrienne has noted, you will be getting an email, and please do pay attention to the time zone because I believe it's listed in Mountain Time and in Eastern Time, so please make sure you pay attention to the time of the webinar to register. It does look like we have another chat box question here. It's about slides being available. You can still download them through qualitynet.webex, and they will also be posted to the hqsi.org. We send out an email notification announcing when everything is posted, and you can also see the handouts that were available as well as the recording of the webinar. If I could just ask the operator to make sure that we get the evaluation polling questions up, that would be great. And it looks like we do have another chat question in here. We can take a look at that. Is there a plan on the national level to have a nationally accepted Interact tool so that the EMRs have more of an incentive to incorporate this into products? It further continues, it seems that where we are moving away from paper, here we have created new forms. It would be great if the EMRs can directly pull the data into a form.
That is a very good question. And, a plan on a national level, certainly not federal government level, but what we have done in creating these tools, the Advancing Excellence and the Interact versions of the tool, which again really are the same tool, we calculate the outcomes the same. We worked closely with CMS and RTI, which is the group that CMS is using to design the QMs. The QMs are using beneficiary claims data. So by definition, by nature, from a nursing home perspective, we don't have exactly the same information and the same visibility, but we have mimicked the logic as closely as possible using the information we have. So which hospitals you're going to count as an acute care hospital, that we start the clock ticking on the date of discharge from the hospital and count for 30 days out, what we call the denominator, all of those things, the Interact/AE or the AE/Interact calculation is the standard. We have thousands of people, thousands of homes using these tools, and it is as close as possible as you can get. Point-click care, if you're using point-click care, they have incorporated that same calculation into the tool. So those using point-click care will have their data automatically moved into, or they'll get the same data, the same calculations, and they will be able to use those outcomes to participate in the campaign. They'll be able to take them from a point-click care report and submit them to the Advancing Excellence website to get that comparison. Plus, I think you'll be able to get comparison via point-click care. I'm not sure about that. And I believe that it's likely, if it's not already happening, that will happen with other EMRs as well.
That's great information. Thank you. Do we have any other phone questions?
Yes, we have one question from Susan O'Donnell with Wiley Mission. Susan, please go ahead. Susan, would you like to ask a question? There are no questions in queue.
Okay, then we'll go over to the chat question. It's a question from Rini Carniol. Do you know to what extent Interact is being used in New Jersey, and what is the national usage currently, and also the usage for advancing excellence?
That is a really great question, and I wish I had looked that up before we got on the line. I haven't looked for a couple of weeks, but we had something like 5,000 downloads of the Advancing Excellence tool the last time I looked, which was well over a month ago. So the Interact program itself, from the national level, the Interact program itself, I'm not sure, but I have to tell you, I'm doing presentations like this multiple times a week. So I know that the tools are being used. They're being used in every state, or in most states anyhow, very widely. And again, for Advancing Excellence, for the Advancing Excellence campaign, the total number of homes that have ever registered during this 6+ years that the campaign has been in existence is now well over 50% of all of the homes. And we're looking to have all of those homes become active participants, meaning submitting the data. And Jen, I'll turn it over to you about to what extent Interact is being used in New Jersey.
Oh, I don't have those exact numbers, actually, but as far as the Advancing Excellence information, I can get that to Rini. I don't have that, and our nursing home person is not in this room right now. So she does have those numbers. I just don't have them in front of me.
This is Loretta. The use of Interact, I would say, is just beginning. Some are much more advanced in the use of the tools, but the product itself, the quality program itself, there's a heightened awareness of it. The hospitals are talking about Interact too. And so I believe within the next 6 months, we will be much more advanced in the use of the total program. The SR and the Stop and Watch are being used, I would say, in a great many nursing homes and even in assisted living. So, maybe Janet then can get those numbers. Would you have it for Advancing Excellence? For Interact is in track, right? Absolutely. Well, with that, we are about at the bottom of the hour mark here. So I would like to thank everybody, Janet, Loretta, and Adrian, for being online with great presentations and answering questions. With that, we thank all participants for attending, and be on the lookout for future email communications from us. Thank you for attending.
Thank you, ladies and gentlemen. This concludes your call. You may now all disconnect.